what I'm going to talk about for the next half hour or so is the systemic effects of ventilator-induced lung injury. And I picked this talk as the first one because in some ways it should be the last one, you might say, because it sort of integrates a lot of what's going to be discussed over the next little while. But I think it gives an idea of why it's really important to understand mechanical ventilation, to understand the concepts underlying ventilator-induced lung injury because of the impact they have on survival or mortality of our patients. So I'm sure all seen this slide. By the way, can you hear me okay at the back? Yeah. I'm sure you've seen a slide, this slide or a slide like this. This is the 28-day survival for the ARDS-NET trial published in the New England Journal of Medicine 2000. And you can see that there was a relative decrease in mortality here of about 22% by going from 12 ml per kilo predicted body weight, which is about 10 ml per kilo actual body weight, to 6 ml per kilo predicted body weight, which turned out to be about 5 ml per kilo in terms of actual body weight, so the proportion of surviving. Another way of looking at this, mortality went down from about 40 to 31% by just using a strategy that included lower tidal volumes. The strategy had more than that, but included lower tidal volumes. So a key question is, what was the mechanism of the decrease in mortality with the smaller tidal volumes? One might think that, well, what's happening is that there's a difference in oxygenation, that with maybe slightly higher PEEP, and it was very slightly higher in this group, oxygenation was better. Turned out, in fact, there was no difference in oxygenation. In fact, the difference in oxygenation went in the opposite direction. The smaller tidal volumes, if anything, had slightly worse oxygenation in the first couple of days. So that wasn't the mechanism for the decrease in mortality. Well, you might think, well, if we're using smaller tidal volumes, there's going to be less barotrauma. There's no difference in barotrauma between the two groups. So it was a bit of a puzzle as to why there's a decrease in mortality in this with the smaller tidal volume group. One hypothesis is that this relates to a concept we've called biotrauma, or release of mediators from the lung due to mechanical ventilation. And that's what I'm going to focus on. I'm going to focus on ventilator-induced lung injury, biotrauma, and how that could impact mortality in patients with ARDS. Because I think it's also important to remember many studies dating back 20-plus years, many of them that Len Hudson actually was an author on, showed that patients with ARDS die not usually from hypoxemia, but they die of multiple system organ failure. So the question is, how do we tie all this together? Well, there's a number of mechanisms, possible mechanisms for organ failure in ventilated patients. We have an effect of ventilation on oxygen delivery. This has been known for well over half a century. The effects of changes in pleural pressure on hemodynamics. If we're not adequately oxygenating patients, you can get hypoxemia that can cause multiple system problems. We have endotracheal tubes, multiple antibiotics leading to nosocomial infections. We have various fluids and inotropes. Inotropes certainly can cause decreased reduction to certain organs, can cause multiple system organ failure. What I'm going to focus on is the direct effect of the lung ventilator system, if you like, and looking at that as a source of mediators. Now, let me now give you just a couple of slides on ventilator-induced lung injury and some of its relevance. I think a key thing we've learned over the last couple of decades from a number of individuals, including Luciano Gattinoni, this is from his study, is that lung injury in ARDS is heterogeneous. We used to think it was relatively homogeneous, looking at PA chest X-ray, looked pretty homogeneous, patchy infiltrates. But as you can see, it's quite heterogeneous. You've got consolidation and atelectasis of the lower lung zones, and with PEEP, this can be partially recruited. You can have areas that appear relatively normal, aren't normal, but appear relatively normal. But the point is that you have a very heterogeneous lung. Now that's what things look like statically. Dynamically, or this is my statically, I didn't load the right file. If you give me 1 second, I will take care of this problem, I hope. I want to show you what things look like dynamically. Oh, we can't find the file. You know what I'll do? I'll play this for you a little bit later because I think it's useful. I have it on a memory stick. I think it's useful to see what the lung looks like when it's dynamically being ventilated as opposed to looking at static CT scans. And you can see areas that collapse and reopen. So I'll get back to this a little bit later. Based on the static and dynamic and a lot of studies, we've begun to realize that there's a number of factors that can aggravate lung injury. And those are ventilation at lung volumes that are relatively high, as shown here. This is a pressure volume curve of the lung showing hysteresis. But there's also ventilation-induced lung injury that can occur with ventilation at low lung volumes. And this can be due to effects on surfactant, opening and closing of lung regions that can cause injury. So the hypothesis I'd like to develop based on this very quick review of ventilator-induced lung injury is that mechanical ventilation can cause release of mediators in the lung, that these factors or some factors can leak from the lungs into the systemic circulation, and that these mediators can lead to end organ dysfunction. So as you can see, where I'm going is to suggest that what we do to with the ventilator to the lung has an impact not only potentially on the lung, but on other organs, distal organs. So let's first deal with, can mechanical ventilation cause release of mediators in the lung? We did a study published about 7 years ago now, looking at this in a model, an ex vivo lung model. And in fact, it was the model that I wanted to show you the movie of, and we'll show you later, that just takes the lungs, ventilates them for 2 hours ex vivo. And it has some advantages. It has advantages in that you can isolate mechanical effects of ventilation on the lung. It also has disadvantages. It's a non-perfused system. It's not really what's happening in vivo per se, but to look at mechanical factors in the lung, I think that it's a reasonable model. And what we did was we ventilated the lungs for 2 hours with 4 different ventilatory strategies. Control group, 3 centimeters of PEEP, 7 ml per kilo, 10 centimeters of PEEP, 15 ml per kilo, 15 ml per kilo, no PEEP, and then a group that had 0 PEEP and end inspiratory stretch equivalent to 15 ml per kilo and 10 of PEEP. This is a pretty high tidal volume, 40 ml per kilo. And we can talk about the relevance of that tidal volume. We then measured various cytokines, and here is one example, tumor necrosis factor alpha. You can see control conditions, medium volume, high PEEP. There was roughly a tripling of TNF, medium volume, 0 PEEP, another doubling. And when we combine both types of injury, if you like, you have about a 50 to 60-fold increase in TNF. There's a break in the x-axis here. To remind you, TNF is a key mediator in the sepsis cascade, thought to be very important in the development of sepsis and a lot of the organ dysfunction that occurs. So here we have just 2 hours of ventilation, mechanical stress, causing release of various mediators. We looked, in fact, at a number of mediators. This was TNF I showed you here. There's also IL-1 beta, IL-6. This is a chemokine, MIP2. And here is an anti-inflammatory cytokine. So it's not just TNF per se that's important, that's increased. You can see the pattern is quite similar in all cytokines. There has been some debate on this study. There's been one study that has not duplicated the results. But I think in general, most studies have found, in fact, most studies have found that you can affect the lung cytokines by ventilatory strategy that one uses. So these data showed that you can get release of cytokines from the lung due to mechanical ventilation. It turns out that these cytokines we initially thought were probably being produced by white cells or inflammatory cells, but it looks like the epithelial cells in the lung, shown here, are a key cell type that's producing cytokines. This is looking at messenger RNA levels for TNF-alpha, and this is epithelial cells. And this here is now immunohistochemical staining for TNF protein. And this orange represents the protein TNF. So that you think about the lung, it's got this huge cross-sectional area, equivalent to a football field, all lined with epithelial cells. If you stretch these, and each one of them produce a little bit of a cytokine, that can have a big dramatic effect. So I think that there's certainly evidence that mechanical ventilation can cause release of mediators into the lung. The second question, if this hypothesis is to bear out, is that factors can leak from the lungs into the circulation. So it's one thing to have them confined into the lung, but can these mediators leak out from the lung? And this is, I'll show you a few studies looking at different factors, if you like, that can leak. This is related to release of bacteremia, release of bacteria due to mechanical ventilation. This is similar to a study that was published with John Marini was the authors on, in dogs. This one I've taken is in rats, largely because it has a nice picture I can use. And the objective here was to examine the effect of peak inspiratory pressure and PEEP on development of bacteremia. So, relatively simple study. Took 80 rats, instilled intratracheal Klebsiella, and then ventilated them with 4 different strategies. Peak inspiratory pressure of 13, PEEP of 3, 13 over 0, 30 over 10, 30 over 0. Did that for 3 hours, started about a day after the inoculation. And then they looked at blood cultures. And here are the results of the blood cultures on the right. You can see that for 3 groups, the relative number of animals with bacteremia were relatively low. One group here had a marked increase in bacteremia. That was the group that had high peak inspiratory pressure, relatively high 30, and 0 of PEEP. Note that another group with the same peak inspiratory pressure, but now PEEP of 10, PEEP here was protective, had a marked decrease in bacteremia. This is true not only for bacteria. This is a study from Brian Kavanaugh's group in Toronto, looking at lung lavaged rabbits who were given endotoxin or not given endotoxin endotracheally. They were then ventilated with a protective ventilatory strategy, 5 ml per kilo, PEEP of 10, or a non-protective strategy, 12 ml per kilo, PEEP of 0. And they then measured endotoxin levels in the serum. And here are in the plasma. And here are plasma endotoxin concentrations. You can see that there's one group here. The pointer's a little weak, but it's the lines and the circles that go up and peak at about 120 minutes. You can see that at this point here, there's a marked increase in endotoxin. This is the animals ventilated with the larger tidal volume. Smaller tidal volume, shown down here, no increase in endotoxin levels. So now you have the fact that ventilatory strategy can cause release of bacteria into the blood, release of endotoxin into the blood. What about release of cytokines? This is from a study from von Bethmann and colleagues, Stefan Uhlig's group. This is now a isolated, perfused mouse model. And they ventilate over time from 0 to 150 minutes. This is TNF in the perfusate. So if you like, it's what's coming out of the lung. And you can see with controlled ventilation, no big difference. With high peak inspiratory pressure, a marked increase in TNF. So again, a few minutes of ventilation can cause release of inflammatory mediators into the systemic circulation. We did this in an in vivo model. David Ciumello was the first author on this, fellow from Luciano Gattinoni's group, published about 5 years. We used an acid aspiration model. This is, I think, a clinically relevant model. You inject acid into the trachea, and it simulates what happened to our patients who aspirate. And we've then ventilated them with 4 ventilatory strategies. High volume, 0 PEEP, 16 ml per kilo. We then added PEEP to that, and then a low tidal volume group, 5 ml per kilo, 0 PEEP, added PEEP to that. And here are the results. This is now serum TNF level, not lavage TNF level. The time is on the x-axis from 0 to 4 hours. You can see again that there's just one group here in which there's a marked increase in serum TNF. That's the group over here, 16 ml per kilo, 0 PEEP. So this tells us, I think, two things. One is, I think the most important thing is the ventilatory strategy one uses can impact not only what's happening in the lung, but also what's happening in the circulation by release of mediators. The second message here is that it's interesting that, if anything, this 16 ml per kilo with 5 of PEEP had greater degree of overdistension, didn't have marked increase in TNF. It's only the group here with 0 PEEP. So again, lots of evidence suggesting that 0 PEEP is certainly detrimental in these animal models, and I'm sure in humans as well. What about human data? Well, this is a study published in JAMA a number of years ago. Mark Ranieri was the first author. This looked now at patients who were patients with ARDS who were randomized to a protective ventilatory strategy or conventional strategy. And you can see here the control group is in yellow. This is entry to 36 hours. IL-6 now, another cytokine. This is a log plot. You can see the control group. There's, if anything, an increase in cytokines in IL-6 over 36 hours. In the minimal stress group, a marked decrease. This is a log plot, so this is roughly a 10-fold decrease in IL-6. So I think I've shown you a lot of data suggesting that that middle piece, that is release of various mediators or endotoxin or bacteria, can occur from the lung in the systemic circulation by changing ventilatory strategy. That's true in cell studies. That's true in an ex vivo model, in vivo models, and true in humans as well. Now, the big question is, does that have any impact on outcomes in our patients? Because that's really what we're after. We're trying to change, impact outcomes. Well, here's another study looking at release of mediators from the lung in patients. This is a study from Stuber published in 2002. You can see here, this is individual cytokines in the number of patients. Patients were treated, now this is patients, not animals. Patients were treated with a lung protective strategy, then they were given low PEEP and higher VT, and then back to a lung protective strategy. Look what happens when the strategy changes from lung protective to low PEEP high VT. Marked increase in a number of cytokines, including IL-6, TNF, IL-1 beta. When lung protective strategy is reinstituted, marked decrease again in these values. Again, showing that the release of mediators in humans occurs due to changes in ventilatory strategy. So as I said, I think I've now shown you that factors can leak from the lungs into the systemic circulation. Big question is, can these mediators lead to end organ dysfunction? Because that's really what's killing our patients, and that's what we want to impact. And the data I showed you so far looks sort of interesting because in other models we know that things can happen, that these mediators can cause disease. Are they causing problems in animals or patients? Well, let me show you a study from Gary published last year. This is a study looking at ventilator-induced lung injury and looking at the effect on gut permeability. And the purpose was to try and examine remote consequences of ventilator-induced lung injury or lung-triggered inflammatory response on the gut. So they're doing something into the lung, they're going to look at the gut. The rats were ventilated with low tidal volumes or high tidal volumes, 10 ml or 30 ml. And what they did to look at the effect of various mediators was to use a neutralizing anti-TNF antibody prior to ventilation for high and low VT. So they said, well, if tumor necrosis factor is important, if we neutralize that, if we neutralize the tumor necrosis factor alpha, will we have an impact on some end organ? And they measured a number of things: extravascular lung albumin, wet to dry weight ratio, gut permeability. I'll show you a little bit of that. So here are the results. First of all, in terms of plasma TNF, control group, 500 picograms per ml, high volume, about 7-fold increase in TNF. As I said, that doesn't prove at all that this is important, but at least it showed that there was an increase in TNF. Here is extravascular albumin. This is control. This tells you basically lung water. Here's with high volume ventilation, not surprising, an increase. This is a control antibody with a control group. So an antibody with small tidal volume, so actually just a control, not important for the moment. Here's high volume with a TNF antibody. You can see that that caused a marked decrease in extravascular albumin. When they used high volume with a control antibody that doesn't bind to TNF, you can see no change. So this suggested that in terms of the lung, in fact, TNF probably is important in terms of ventilator-induced lung injury because it does cause blocking the TNF decreased extravascular albumin. Here's what happened to gut permeability. Here's gut permeability index on the y-axis, same 5 groups across the bottom. The important groups are this one, high volume. You can see with high volume there was an increase in gut permeability. Control antibody, this is with low tidal volume, no effect. This one here, the second one from the right, the pointer's not very bright. This one labeled HVAB. You can see that this was a marked decrease in gut permeability now by using an antibody to TNF. And when they used an irrelevant antibody on the far right that didn't bind TNF, no effect. So these data suggested that, gee, that maybe what we're doing by release of mediators may be important because here, blocking one of those mediators actually improves permeability both in the lung but also in the gut. We published a study last year in JAMA trying to sort out what might be the mechanisms by which ventilator-induced lung injury might cause distal organ dysfunction. And I'll take you through this a little bit slowly because I know you're not all experts on some molecular aspects, but I think this is worthwhile thinking about. The model set out to develop a model of systemic effects of ventilator-induced lung injury. Most of the studies have looked at relatively short time frames, looking at the lung per se. We wanted to look at what happens to distal organs. So we used anesthetized rats, intratracheal injection of hydrochloric acid, again the acid aspiration model, randomized the animals into groups, low tidal volume, high PEEP, which we thought was protective, high tidal volume, zero PEEP, not protective, and then made a number of measurements. I'm not going to show you all of these measurements, including hemodynamics, etc. I just now want to go a bit aside and introduce another concept to you, and that's the concept of apoptosis, or programmed cell death, because that's one of the key markers we used because we felt it would be an early indicator of what's happening to cells in distal organs. And this is a very important mechanism that was described over the past 20 years. And basically, cells can die by either necrosis. They essentially spill their guts, the cells pop open, release everything, or they can die by a programmed method of cell death called apoptosis. Turns out that this is very important in terms of development, very important in terms of cancer, etc. There are a number of mediators that are important in terms of apoptosis, including something called FAS and FAS ligand and caspases. Let's just focus on FAS. I think the specifics are unimportant. The important thing is that there's a molecule that can trigger apoptosis, can trigger cells to take a programmed cell death approach. Is this important in ARDS? Well, we don't know for sure, but there's some data. This is from the Seattle group. This is from patients. This is data from patients with ARDS. You can see here on the bottom left here, this is on the y-axis apoptotic cells. What these investigators did was take a human cell line, distal epithelial cells, and expose them to bronchoalveolar lavage from patients. And the patients were either patients with ARDS or patients at risk. They then looked at percentage apoptosis, how many cells became apoptotic, and then tried to block the cells by block the apoptosis by taking either anti-FAS ligand or something called a FAS fusion protein, just different ways to block this molecule. You can see here the control antibody. So this is bronchoalveolar lavage applied to epithelial cells, patients with ARDS. The epithelial cells are from normals, but the lavage is from ARDS patients. You can see that there's a marked increase in apoptotic cells compared to normal lavage. When they blocked FAS by various mechanisms, they had a decrease in this apoptosis. So this suggested that there was something in the bronchoalveolar lavage fluid of patients with ARDS led to apoptosis, could be blocked by something that blocks FAS. Is this important? Again, we don't know for sure, but when they looked at soluble FAS ligand, shown here on the y-axis, and those patients who went on to live and those patients who went on to die, patients who went on to live had lower levels of soluble FAS ligand than those who went on to die, suggesting that this might be important. So that's a bit of a background. That's the human study. Now we're going to go back to that rabbit study I started to describe, which was published in JAMA. So we looked at a number of outcomes, looked at blood pressure, no change in hemodynamics among the groups. We then looked at apoptosis in distal organs. This is now the kidney. This is a tunnel assay, non-injurious ventilation. You don't see much here. The injurious ventilatory strategy, this is a piece of the kidney. You can see these arrows pointing to these yellow little circles. These are apoptotic cells. So an injurious ventilatory strategy that had no effect on hemodynamics caused an increase in apoptosis in the kidney. So what you're doing to the lung is having an impact on the kidney. We quantified this, and that's shown down here. The apoptotic index, very low in the non-injurious group. In the black, the injurious group. In the small intestine, in the villi of the small intestine, similar findings with increased apoptosis in the injurious group. In the crypt, there was nothing there. So this suggested that, as I said, what you do to the lung has an impact not just on the lung, but also on the systemic organs, on kidney and perhaps the gut. The gut is an interesting one because it's been suggested that the gut may be the source of systemic inflammatory response with translocation of bacteria. Here's a mechanism by which mechanical ventilation could amplify that. In fact, if you have ventilator-induced lung injury causing release of mediators, causing increased apoptosis in the gut, that might make it easier for translocation to occur, which might be another mechanism to cause systemic inflammatory response syndrome in MODS. What about human data? The study I showed you earlier from Ranieri, we had samples left over from that study, and we looked at changes in FAS ligand over a period of a few days versus changes in creatinine as an index of worsening renal function. And you can see those patients who ended up having higher FAS ligand over time had higher levels of serum creatinine, suggesting that this may be important in terms of organ dysfunction, specifically renal dysfunction. Having said that, thank you. Having said that, is there evidence that the FAS ligand is important in animals or humans? And there isn't any in humans per se, but we have some preliminary data in animals that I think are quite interesting. This is soluble FAS ligand. We used a blocker for soluble FAS ligand and looked for apoptosis in kidney epithelial cells in that same rat aspiration model. And you can see here, just focus on the cortex, these three panels, low tidal volume ventilation, high tidal volume ventilation with control antibody, high tidal volume ventilation with an antibody that blocks FAS ligand. And you can see that the control antibody, high volume, a lot of apoptotic cells shown by these arrows. When we blocked FAS ligand with the antibody, very few apoptotic cells. Well, that's interesting, but does that impact function? Because we're still talking here about apoptosis. And it turns out that in preliminary studies, we only have N of 3 in each group, that if you look down here, this is the change in creatinine from baseline. Look at the yellow. That's control antibody plus high volume. So injurious ventilatory strategy causes an increase in creatinine. We use FAS ligand antibody with the same degree of high volume ventilation, same hemodynamics. There's a decrease in creatinine. So these are pretty preliminary data, but at least are suggestive that what we do with the ventilator can cause release of mediators, in this case FAS ligand, and that this FAS ligand might lead to something happening in kidneys and elsewhere, and that that may be detrimental, and if one blocks that, one could mitigate the impact of mechanical ventilation. So let me summarize then on this slide by looking at mechanical ventilation and the effects on the systemic circulation, the effects on organ dysfunction. We've known for a long time that mechanical ventilation can cause biophysical injury to the lung due to overdistension, cyclic stretch. We can get barotrauma. This is really largely due to changes in intrathoracic pressure. We also know that there can be an increase in alveolar capillary permeability, huge effects on hemodynamics, clearly, by increases in pleural pressure and organ perfusion. We've begun to realize over the past 7 or 8 years that there can be more subtle injury, biochemical injury, or biotrauma, with release of various mediators in the lung, various cytokines and other mediators. These mediators can attract neutrophils. There's chemokines that can attract neutrophils. And I think importantly, one can get spillover of various mediators, whether they be cytokines, whether it be endotoxin, whether it be bacteria, into the systemic circulation. These potentially could lead to distal organ dysfunction. Perhaps one of these mediators that's important in humans is Fas ligand, soluble Fas ligand. We don't know for sure yet. It's just speculative at the moment. And this could potentially all lead to increased mortality. So I think this is, at the moment, still a speculative figure, if you like. But I think there is some data, both in animal models and in human models, suggesting that what's happening, what we're doing to the lung, has an impact on how we're ventilating the lung, has an impact not only on sort of the oxygenation, the PCO2, not only on ventilator-induced lung injury locally, but also on what can happen outside the lung. And that's pretty important because, as I said earlier, most patients who die from ARDS die from multiple system organ dysfunction. And this here is a plausible mechanism to explain that. And the important part here is that this also then opens up opportunities to intervene. One can think of novel ways to intervene to try and mitigate this injury, and I'll cover that in my talk tomorrow, when one can't get a ventilatory strategy that's non-injurious. So thank you very much. Be happy to take any questions from the audience. Are there any microphones out there, or is this going to have to be okay. Questions, comments? Len?
We might wind up discussing this, but you showed Luciano's CT scan, and you said the lung injury is heterogeneous because all of the non-aerated lung, most of it was at the bases. But if you flip that animal or patient over, all of a sudden that changes, and you have more of the non-aerated lung now still in the dependent portion, but in the rest of the lung. So I'm wondering if the lung injury isn't more diffuse than these CT scans in one position would indicate, but that the manifestations of that injury might be more localized. I actually think the injury itself is probably heterogeneous, but maybe not as much as a single CT image would suggest.
I agree. In fact, maybe we get Luciano a microphone as well, and I'll give you my take on it until he gets the microphone. And that's, I said that the non-dependent lung region looks normal, but it's not. And I agree with you. There's gravitational effects. And so I think that it's not like that's normal lung and the rest is not normal. But I'll let Luciano comment on that.
Very briefly, because there is some misunderstanding on it. When we start with a CT scan, the first CT scan were taken at end expiration, and we found consistently density down. And so we call, okay, we have the small lung up, we call it baby lung, and was correlated with low compliance and so on. Then when we start to put the patient in prone position, we found that the baby lung was still up, was not an anatomical entity. So we went to look the regional distribution of edema, of the excess tissue mass, and it came out that all lung is affected, non-dependent and dependent. The tissue, the various levels, have about a double of the excess tissue mass. the appearance is due not to more edema down, but less gas, because the lung squeezes the down regions, collapse on its own weight. So when you put, at the end of the story, it's a sort of sponge model. The big sponge, you put the sponge in the water, and I had some CT scan of the sponge too. And you can see the same effect. You have more density down, even if all the sponge is wet, because there is the gravitational forces for that. And this explains, so I think, in the real ARDS, what we call ARDS, which is a rare phenomenon, it's not so common, I think all the lung is involved by the inflammation. The physical consequence in terms of density and then gas exchange and so on depends a lot on this rough phenomenon as the gravity and so on. I think all the lung is taken.
So in the space station, Luciano, in the space station, it would be very homogeneous. Yeah. So we're going to ask George W. to send Luciano up in the next spacecraft. Any other questions? Yeah.
Yes, that study you're doing with fast ligand looks very interesting. What I want to know, what is the source of the fast ligand? Is it actually the epithelial cells, or are you releasing the inflammatory mediator released from your epithelial cells is now activating your neutrophils, which are now releasing your soluble fast ligand? Because activated neutrophils are a well-documented source of soluble fast ligand, and your inflammatory mediators are all release factors for soluble fast ligand.
That's a very good question. In fact, we're trying to answer it right now using two different models, using in collaboration with Stefan Uhlig to look at a perfused model where there's no white cells, and also do immunohistochemistry staining and other staining to be able to determine. Because I think that's a very important question. We don't have the answer there, and I would only be guessing at the moment because neutrophils are a very likely source. But we were surprised, as I said before, with the epithelial cells turning on. It turns out epithelial cells can produce pretty well everything. So we don't know which it is, but we hope maybe in a year to have that answer for you earlier. Any other questions? Comments? Okay, I think we can, let's move on.